Hello. Next, I'd like to speak to you about the treatment of acute allergic reaction, including anaphylaxis. And we'll also cover some common bites and stings, since bites and stings are sometimes associated with anaphylaxis. We'll do them all together. All right, anaphylaxis. This is a true medical emergency. No time to look up the treatment for this in a book, and there will be questions on the board of this. All right? All right. Anaphylaxis is life-threatening, and it usually it may be an IgE-related or non-IgE-mediated hypersensitivity reaction. The patients will present very abruptly, and the common causes are, well, there's many causes. In medicines, what are the common causes? Penicillin, aspirin, sulfa medication. There are many foods that cause this. Shellfish, nuts, peanuts, that's the big one. Wheat, eggs, soybeans. Of course, we all know the yellow jackets and bees, the Hymenoptera group of insects. And of course, iodinated contrast material that we use for infused CAT scans is another common source of anaphylaxis or allergic reaction. Minor allergic reactions, patients just have urticaria or hives, right? With anaphylaxis, urticaria may or may not be present. So just because there's no urticaria, they have the other symptoms of anaphylaxis, it's still anaphylaxis, okay? Many patients have an itching feeling from the histamine release, and many patients will have angioedema, swelling of the lips, swelling of the airway. Patients present with abdominal pain and cramping. Some have vomiting. Bronchospasm is common, like asthma. Many feel shortness of breath and have chest pain from the ensuing hypoxia. Hypotension is very common, of course. So, to review, patients will come in and say, I was exposed to a bee sting, and I've got kind of flushed, I'm kind of hives, urticaria, I'm itchy. As soon as they get hypoxic, they get anxious, right? Patients come in and say, I have a lump in my throat. Don't assume it's a panic disorder. Ask them about exposure to allergens. This might be the anaphylaxis case. Okay? Patients that are hoarse, have hoarseness, this indicates laryngeal edema. All right? Big deal. You have to treat it immediately. Angioedema, swelling of the lips and tongue and the pharynx. All right? Anaphylaxis is a sudden thing. You get stung by the bee, and within minutes to an hour, you are very critically ill. Right? If you're going to die from an allergic reaction, it's usually that first hour or so, first hour or two. So this is a true emergency medicine case. All right, the diagnosis is usually pretty straightforward on the anaphylaxis case. They usually don't make the differential diagnosis difficult because they usually tell you they just had penicillin or were just stung by a bee. But occasionally you can get confused with a couple other clinical entities. Certainly status epilepticus could have some similar features with a sudden onset of a lot of dyspnea. But status epilepticus won't have swollen lips and they really don't have itching, right? And status epilepticus does not have any signs of upper airway compromise. They have no hoarseness or stridor. Whereas anaphylaxis has hoarseness, stridor, all signs of laryngeal edema. Occasionally you can get this mixed up with epiglottitis, but again, epiglottitis, that has a high fever, they had a sore throat for a couple days first. It's quite possible to get this mixed up with an upper airway obstruction, just like getting a piece of a peanut or a hot dog in the airway. All right? And the difference between vasovagal reaction, could that be confused? Because you're shocky with vasovagal reaction, your blood pressure drops. Well, vasovagal reaction's over in a minute or so, and anaphylaxis isn't. All right. You could do a tryptase level to prove that the patients had anaphylaxis, but you know what? If you're waiting for the tryptase level, the patient's already expired. So this is a clinical syndrome. You do not use blood tests or diagnostic tests to diagnose this. You recognize it based on the constellation of history and physical, and you treat. Okay? All right. So there's a few other things that come up now and then. If the patient has just ate some spoiled tuna and has urticaria, hives with some vomiting and diarrhea, food poisoning picture, that might be what's called scromboid poisoning. The treatment is the same as anaphylaxis. You give antihistamines. If they say there's a family history, it might be a rare thing called hereditary angioedema, which is a C1 esterase inhibitor deficiency. And you would replace that with fresh frozen plasma or the concentrate. You may have patients on lisinopril or any other ACE inhibitor, and they can have swelling of the face and lips and laryngeal edema as well. Okay? And lastly, I don't want you to get this patient confused with, is panic disorder. Patients with panic disorder have no stridor, they have no hypoxia, their pulse ox is normal, their lungs are clear. Okay? All right, so how do you treat these folks? Airway, breathing, circulation, right. Keep their oxygen level up, give them as much oxygen as they need, right? If they're showing signs of stridor or hoarseness, you might as well intubate now, because if you wait, the edema will be so great you won't be able to intubate at all, and you'll have to do a cricothyrotomy. Okay? These patients are completely hypotensive and need large amounts of IV fluids. They need normal saline or lactated ringers. A mainstay of therapy is epinephrine. Now, for patients with a pulse, you don't give IV epinephrine. This is a good place for IM. Some people would use subcube or IM epinephrine, 0.3 milligrams. And this will very much stabilize the patient. Yes, the patients that are 65, you have some concerns about giving epinephrine where they may have some previous heart disease. But if patients are crashing from anaphylaxis, you can give a very tiny amount, maybe 0.1 milligram. Okay? If patients are in a premorbid state and they're just about to suffer cardiac arrest with very thready pulse, no blood pressure, they're already intubated, sometimes then you can give 1/10 of a milligram of epinephrine IV very slowly. But the rule is the 1 milligram, the 2 milligram amounts of epinephrine IV, that's reserved for patients that don't have a pulse. Okay? So, after oxygen, epi, IV fluids, next we're going to give Benadryl, histamine blocker, diphenhydramine. Benadryl can be given PO or IV. All right? The next thing in the treatment is you want to give corticosteroids. So if the patient can swallow, doesn't have any laryngeal edema, you can give it PO like prednisone, or just give the dose of steroids IV. Here I have listed methylprednisolone 125 milligrams IV as kind of a standard dose. All right. Some people like to give H2 blockers, cimetidine, that's Tagamet, PO or IV also. All right. If the patient's wheezing, go ahead and give albuterol. Lastly, we should also consider removing the source of the anaphylaxis. And what I mean by that is, if you get stung by the bee, the Hymenoptera, sometimes the stinger is still in the skin, and the little venom sac is there. So to get that out, what you do is you take a tongue blade or a credit card, or if your fingernails are long, and you flick the stinger out of the skin. American Express works. They take Visa too. So the reason why I use a stick or a credit card to flick out the stinger is if you grab the little stinger, there's a little venom sac there. And by grabbing it, you're actually squeezing more of the antigen into the patient's circulation. Okay? Now, I don't want to give you an idea that you give epi, then you wait and see the response. And if they're not better, well, then I give them some Benadryl and I wait and see. Are you better yet? No? The treatment of anaphylaxis is everything together, all right? IV, fluid resuscitation, oxygen, epinephrine, Benadryl, steroids, all in the first 5 minutes that you're starting to treat the patient. Okay? All right. Now, one of the issues is patients get better quickly when they have when they get their epinephrine, but the epinephrine wears off, and then the symptoms return, and the chemistry of anaphylaxis shows that that the symptoms will persist for many hours. So if you find someone sick enough to get epinephrine, don't send them home right when they're better 20 minutes later. You have to observe them for 4 to 6 hours to make sure that they're really going to be stable. Anyone after a period of observation is still having any hint of hoarseness or stridor or laryngeal edema or abnormal vital signs or dyspnea, they need to be admitted to the hospital. Patients that have allergic reactions just consist of hives with no abnormal vital signs, with no troubles breathing. Those patients can go home on Benadryl and steroids. Eventually, when patients do go home that have anaphylaxis, they should have an EpiPen, which is their own injectable epinephrine, and they should understand that if they ever use their EpiPen, they should also simultaneously call 911. Of course, avoiding the allergen that sets you off is always important as well, and these patients should be referred to allergists for desensitization as well. Thank you. That is the end of anaphylaxis.